Yes, I think, Kevin, very much the missions between the health center network and the REC are very mutual, and they're collaborative. If you think about what we're doing, what we've already been doing, from the standpoint of sustainability of the HCCN, our members as well derived a lot of benefits from using our services, being able to pull those resources. That saves them funding, allows us to extend the reach of the capabilities that we provide into those organizations. And so we were funded through those kind of opportunities and benefits of those individual members. From the standpoint of looking, going forward, very much see the opportunity of being able to form more relationships and partnerships. Up to this point, the primary outreach has been within the community health center facilities themselves. Now we're going to have a wider reach. We're going to have many more physicians, number one, learning about us, taking advantage, hopefully, of those same kind of economies of scale and opportunity that the health centers have up to this point. So it's very much a win-win. And as I said at the start of my presentation, I'm very surprised that more HCCNs around the nation did not actually outreach and extend themselves into the opportunity for regional extension centers.
And I think with my organization, I think one of the differences is that contractually, our primary vendor for the product we're offering our membership, we're not allowed to offer that to for-profit physicians and commercial organizations. So that actually puts a fence in there already. I think the other piece that we need to look at is that we're also slightly different in Oregon, where because of the adoption that's already in place, about 50% of the market is actually 2 products. And so within there, we're looking at adoption of a small number of clinics. We're looking at an additional maybe 15 to 20% of the providers in the state organizations that will actually come onto EHRs during that term. So most of them are already on a product, they've already gone through their selection criteria, and really for us, it's about the additional services, the functionality. We also have to look at the fact that the stream and the funding opportunity that comes in on there and the revenue that actually is generated doesn't necessarily cover the cost of implementing these solutions and being sustainable to the extension centers. And so the surrounding products that have to go in there in the service suites, the consultative services, a lot of that can be outsourced to organizations that are already providing that. So a lot of it is going to be about the management of external service organizations and providing service suites that make sense to those clinics.
Doug?
So thank you very much for your presentations. I think it's exciting to see the kind of work that all of you are doing. The question I have, many of you have talked about kind of how you connect people together and use the network in addition to the other sorts of services that are being provided. I'd like each of you to sort of talk a little bit about what that means when you say you're connecting these folks together. So for example, Meaningful Use Stage 1 is all about conformance to a series of standards. But clearly, as we move forward and start to have additional exchange of information, there needs to be sort of common ways of doing that. And I know some folks are implementing HIPAA-compliant secure messaging, for example. That's one of the goals there. I'm just curious what that means, and to what degree do you see standardization across that exchange being an important part of what you do going forward?
So this is a subject dear to my heart. I spend my entire life currently working on this. So for us, I think one of the major components is getting past this understanding of standards. And there's a lot of standards out there for the interchange of information, and a lot of them have a myriad of different interpretations across organizations on how to implement. So when we look at laboratory standards and the exchange of data in a laboratory system, when those results are coming back in, are we going to use the hospital system's terminology, the component namings, the results coming back in? Or are we going to start to work with the hospitals and with the other laboratory vendors to come to the national standards, the new eLinks, the 2.51 standard? So at Ocean, one of the things that we looked at early and have just completed the process is working through with ourselves, leading a project for our vendors and also for 2 national labs, Quest Diagnostics and LabCorp, to basically bring them into a completely standards-based eLinks results delivery. The other thing that we looked at is how to deliver data both between hospital systems and the clinics we serve. That is conducted right now through the HITSB C32 continuity of care document. We're using the CDAR2 standard specifications to deliver data backwards and forwards between the clinics and the hospital systems themselves. And then also looking at the NHIN connectivity. And so beyond the Social Security Administration contract work that we're working on to be able to provide records back to Social Security, we're also looking at NHIN as a method of actually providing exchange of data specifically across state boundaries, not necessarily internally, but we're also working with a couple of national HMOs and organizations to look at using NHIN to establish connectivity to larger organizations as a demonstration pilot, including the ability to use NHIN Direct. One of the things that we're very interested in, and actually I'm predominantly behind internally, is the support of the SMTP standard for delivery. I think that a method of delivering data both to physicians that don't have an EHR in-house, are not necessarily connected to a HIE organization, and also the ability to deliver information to a patient is critical. And I think that standard has a lot of promise for delivery of data to them. And so, I mean, our focus is on how do we get that standards information stored? How do we do the normalization of that data? Do we take medications from the multiple national standards that are out there, or national agencies that are performing databases, taking it to the RX norm standard? And then how do we translate that back to the standard of another receiving organization so that we're able to take that medication information and exchange it between systems that are on different database structures? So I think it's very important that those standards go into place.
And just could you introduce yourself before you speak? This way the folks out in hinterlands can know who's speaking.
Very good. This is Walt Culbertson. A great question. When you look at how many vendors are in the marketplace in the state of Florida, how many local exchanges exist, not only from the standpoint of the regional health information organizations, but hospitals who have been at the forefront of being able to connect the physicians that support their facilities. And you take a look at where we're trying to go, I think standards are absolutely critical. When you think about the fact that the information that we're sharing and we'll put to use is not just, you know, as simple as the banking world. It basically is critical. It's life and death. And so to know that we're not mixing apples and oranges as that information is exchanged is critical. How much time do we want physicians to spend in trying to discern and basically analyze what they just received in varying formats and so forth is really a critical question. So I think we do have to take a look at standards-based. That is a key opportunity, I think, as Paul has highlighted. And then when you take a look at what we've done and where we are within the local communities, it really is helping physicians see what the health-centered control networks have done and being able to leverage that very directly within those communities. In some cases, in our rural communities, no HIE exists. That might be a very good starting point to be able to leverage and connect physicians. So very much being able to leverage those resources and those delivery capabilities that are local, organically growing them and building them out and then connecting them through standards is very much the opportunity.
This is Michelle Russell. I completely agree. Standards are a must. If you look at just the labs today in our country, regionalized labs in the same company like Quest have different codes, different test codes, different component codes for the same test. Across this country, one company, different regions, different codes. You know, for standardized reporting, to be able to pull any of that data out, you've got to link you've got to have the standard set. And I think, you know, we're looking for policy to dictate that these things have to happen. So one of the things that we're doing with our health centers today to be able to pull that data together, to be able to share it, at least among the member centers we have today, is we have partnered with an organization that will take that data and put it in a data repository. So they'll take our electronic health record data, our electronic oral health record data, our behavioral health record data, put it in one place where the provider logs into the system, has a desktop that pops up that shows his different measures. When the provider logs in, if that provider's pediatric provider and wants to see the immunizations and the stats for that particular provider versus all other providers, some other providers across the network, the provider can do that. And that is something that we're looking to have implemented starting in the next 6 months to the next 18 months to have that complete, so that they can see that total picture of the patient's health today. And then that product should be able to position us to be able to exchange data across the community, across the regional extension center, and hopefully, ultimately, across the country.
And Tom?
Hi, I'm Tom Fritz, and I represent the American Hospital Association on the board. Yeah, I really appreciate your presentation and what you're all doing. Can you, since you're in the rural communities, can you talk a little bit about what you're doing with rural hospitals and critical access hospitals as part of the REC and your initiatives?
Yes, we've actually applied for the extra funding to be able to support CAHs, and we view them very critical from, no pun, critical access facilities, but certainly within our patient populations, those facilities work hand in hand often with the community health centers. So being able to align them and being able to focus on them is a great opportunity for us. Looking at basically where we are in Florida with so many underserved migrant workers, those facilities and the health centers working together are critical. So one of the great opportunities with the REC and our funding and the ability to be able to reach into those communities and start the dialogue. A lot of this is getting folks to talk, and in some cases breaking down any competitive barriers that exist is really key to this. So leveraging the strengths of the health center community networks, being able to really focus on how we connect folks is, I think, a key opportunity as we move forward, and very much among those are those facilities that are helping serve the population that is very challenged today. I think if you think about where we're headed as a nation from the standpoint of where we are today with unemployment, more folks needing care that cannot have general access to it. Look at the ability and what we're going to do under the new health insurance reform to give more individuals insurance. A lot of that is going to be built around Medicaid. I think the explosion and the number of patients showing up into those facilities is going to increase dramatically. So being able to align the stakeholders in those communities, have some continuity of care and how that's delivered as patients are going in and out of insurance, being able to make certain that we're coordinating care across those communities, I think is a key opportunity. And this was Walt Culbertson.
And Laura?
So this is Paul Matthews. So one of the questions, I think it's a very good question. So just like Walt, we've actually applied for the additional funding stream for the critical access hospitals, the $12,000. The $12,000 is not going to make a huge difference in the implementation of EHRs in a critical access facility. And especially in a rural area where the ability to get trained staff and implementers to a region to implement it is going to eat up that money on transport costs alone. And so one of the things that we need to look at is how do we partner with the major hospital systems in the regions to provide a offshoot or services to those access hospitals, and also how the funding from the extension centers will flow from the Medicaid or Medicare, because the majority of the providers working in our state in those critical access centers are actually not working there as their primary facility. So their funding streams are going to go to the clinics or to the provider within the clinic setting and not to the access hospital itself. So it's going to be a double whammy to the critical access hospitals themselves in those communities. We have reached out to a number of them. We're working with the Hospital Association in the state to try and pull together the critical access hospitals to see if there's an ability to do a group purchase or a group method of tying everybody together into one system. That means they have cross-training, that the providers, if they go and volunteer or move within the regions, are able to provide services under one structure. And so I think it's very important to include them.